Good afternoon and welcome to a briefing of Protector Province, BC. We are March 1st, 2023. My name is Dr. Lyne Filiatrault. I'm a retired emergency physician and a member of Protector Province, BC. And today I'm joined by Dr. Susan Kuo, who's a busy family physician running her own private office in Richmond and also works at several long-term care homes in Richmond. So for those of you who are new to Protector Province, BC, we're a grassroots initiative made up of physicians, nurses, teachers, health scientists, and health policy advocates, as well as community advocates. We came together at the beginning of the COVID-19 pandemic to help keep British Columbians informed on how to best protect themselves against COVID and against all the harms that are associated with COVID. As well, one of the other role that we play is to leverage media and people in the public to nudge government to do the right thing and use evidence-based policies when it comes to managing the pandemic in British Columbia. Our goal, like everybody else, is to end this, should I say, damn pandemic. So before we dive into the topic today, I just want to take a moment to center ourselves and acknowledge that the team is broadcasting from the ancestral, unceded, traditional territory of the Coast Salish peoples, specifically the Squamish, the Musqueam, and the Tsleil-Waututh. And I myself am in New Westminster, and I'm on the unceded and unsurrendered land of the Alcomilan speaking people. I want to recognize that we are settlers on their lands and that we do our utmost to abide by the Truth and Reconciliation recommendation and the 94 calls to action. That's it.
Lyne, thanks so very much again for doing such an excellent video presentation on Paxlovid. For those who didn't have a chance to watch the video, can you give us some of the key points from your presentation?
Yeah, the reason I thought that we would talk about Paxlovid, Susan, is that our hospitalization have gone up, I think in the last week by about 25%. And Professor Tard Moriarty highlighted that we're just starting a new wave or surge, if you will, of COVID infections in Canada, but also in BC. So I thought it was time to talk about Paxlovid because the impression is that, and in fact, it is being underutilized in British Columbia. So the papers that I reviewed were about showing that in the pre-Omicron phase during Delta, there were more admissions and more death, but even now using Paxlovid during Omicron and its subvariants, it has significant impact. And that includes impact in people over the age of 50. That was one of the papers that I reviewed. And it showed that there was significant diminution in risk of hospitalization or death across all risk categories. Obviously, the more risk that you had, the bigger effect there was in terms of reduction of your risk of death and hospitalization, but it doesn't minimize that there was risk across all risk factors. And the other thing that I wanted to point out is that when we talk about severe outcome, we need to revise the definition of severe outcome because all the studies, and even here in BC, looks at 30-day mortality. In fact, we know that you can die from COVID well after 30 days. And none of the studies looked at that. And in addition to that, the big elephant in the room that I talked about is long COVID. We have so many people in the world, in BC and in Canada, that are really disabled by long COVID. We have no treatment. And it behooves us to prevent long COVID. And again, looking at the role of Paxlovid. And on top of that, we started off not knowing who is at risk of long COVID. Now, some people have, if you want, shown themselves. And we need to protect people that have either recovered from long COVID or are still suffering from long COVID. And we know they're at high risk of relapse if they get reinfected. So wanted to show that that's another role for Paxlovid in this high-risk group.
Yeah, I agree. I think this is a very important drug that's going to make a big difference to the treatment of COVID as we're moving forward. I've been using a lot of Paxlovid in my long-term care places as well as in my regular practice, and it's really making a huge difference in reducing hospitalizations and deaths.
And how quickly have you seen an effect in the patients that you're using it with in long-term care, for example?
Sometimes I have patients that are very ill and their oxygen levels have dropped way down to 65%. And within 48 hours of taking the medication, they're feeling clinically much better. They symptomatically and clinically examined, they're much better. And their oxygen levels are coming back up to 90% within 48 hours. So,
okay. One of the things that is clear with Paxlovid is that we have to use it within 5 days of symptom onset. And I think there's a lot of misconceptions still happening about that. We see on Twitter people being told, oh, just wait and see if you get sick, and then we'll decide whether to use it. It doesn't make any sense to me. What do you think about that?
it's absolutely crucial to take the medication early. Because by taking the medication early, you're using the Paxlovid to prevent the replication of the virus and preventing them from disseminating and getting into your cells and having your cells make lots of copies and disseminating. And because once this happens, you have more severe disease and higher chance of having long COVID.
Okay. So you said you used it a lot in long-term care, but what about in your family practice office? Are you seeing people that you're able to prescribe Paxlovid for? Because it's really tough to get it out there in BC. There's so many restriction on using it.
It's true, but if you look, there are actually some newer criteria that have come out that make it a lot easier to prescribe. So for a fully vaccinated person that's 70 years and older, in addition to for one of those 3 recommended conditions that they've written down on the prescription paper, like congestive heart failure and stroke, if you take a look at the BC CDC website, there's other very common conditions like asthma, COPD, smoking, obesity, frailty, dementia, as well as other social determinants like mental health, homelessness, that actually will make that you can use in your criteria to get them the medication.
So you're saying there's more criteria now that are available
Yes.
to count towards those 3 conditions that people that are fully vaccinated over the age of 70 need to meet in order to get Paxlovid.
For sure.
Okay. What are some contraindication where you actually can't use Paxlovid?
Really, there's only 3 absolute contraindications: severe kidney disease, severe liver disease, and previous allergic reaction to Paxlovid.
Okay. And what if people are just borderline, they don't have great kidney function, but, they're not on dialysis, and can they still use Paxlovid?
Yes, there's actually 2 different dosages based on kidney function. So if the kidney function is absolutely normal, there's 1 dosage, that's GFR greater than 60. And there's another dosage for people who have less than 100% normal kidney function, but more than GFR of, say, 30. So yes, there are 2 dosages depending on kidney function.
Okay. And now, what are some side effects? So if somebody takes Paxlovid, what do you tell them to expect in terms of side effects?
Well, the side effects that are listed are nausea, vomiting, diarrhea, headaches, and metallic taste, and potential high blood pressure. But I have to tell you, Lynn, I've used this drug a lot, and I rarely see these side effects in any of my patients. And keep in mind, this is for a 5-day course of medication. It's not a very long course.
So you're saying, something to keep in mind, maybe bear with it so you get the benefit of not developing severe COVID.
Exactly. I mean, the 5 days of a little bit of nausea and vomiting is well worth it not to have the long-term disability of long COVID.
Yeah, I have one relative who took it, and she complained about the taste, but she stuck through it as well.
Mm-hmm.
Okay, and now, give me a second here. One of the things that we've heard with Dr. Fauci and President Biden in the United States is this a thing called rebound effect. Can you tell me a little bit about it?
The actual numbers of rebound cases is very small. And some of the studies say as little as 2%, some of them saying as high as 10 to 14%. But in actuality, rebound can even occur in people infected with COVID that did not get treated with Paxlovid.
Okay. So whether they take it or not, they might get rebound.
Exactly.
Yeah. And I heard, I've read some of the cases and people feel better and then all of a sudden their symptoms come back, right?
Mm-hmm.
That's what rebound is, essentially.
That's it.
Now, maybe one of the things to highlight is that if that happens, people should retest with their rapid test, because if they turn positive again on the rapid test, they're infectious again. So something to keep in the back of our minds so that we don't get the rest of the household infected if that happens, right? Okay. Now, the other fear that I've read about is people worrying that, if we overuse Paxlovid, we're going to get resistance. And it's about one of the last medications we have. We don't have monoclonal antibodies anymore that we can use because the virus has become resistant to that. So what do you say about this concern about overusing Paxlovid for fear that the virus becomes resistant?
I mean, resistant to any antiviral, any antibiotic is theoretically possible. But right now in the real world, there's actually been no documented cases of Paxlovid resistance that I could find when I did a literature search. There are only some lab-induced situations where they've actually genetically engineered in mice and mouse models some viruses that could be Paxlovid resistant. But in real world, in our use of Paxlovid, we haven't actually seen any cases yet.
Susan, the cynical in me thinks if people are worried about resistance, I don't think BC is contributing to resistance to Paxlovid at this point with the amount of underutilization we're doing. And the other argument, if people are worried about the virus being resistant, I think then we need to control transmission and limit the amount of infection, because that's really how we could deal with viral resistance.
Yeah, I totally agree, Lynn. And can you explain to me why in BC we have close to 140,000 treatment doses of Paxlovid given to us for free by the federal government, but they're all sitting in shelves and warehouses, and we've only used less than 10% in BC? Why do you think this is happening?
I think that public health has done really a bad job about showing the benefit of Paxlovid utilization. I think even in the people that they agree it's useful, they're not getting it out to them. I'm a clinically extremely vulnerable, I'm part of the clinically extremely vulnerable group. And I can tell you that when I called to get a preemptive prescription, neither the physician nor the pharmacist were aware that was available in British Columbia. So people that are currently eligible for, to access Paxlovid don't know about it. And then the other question I had for you is, we hear our public health officer, keep highlighting the amount of drug interactions with Paxlovid. How true is that?
There are definitely a lot of drug interactions, but they're manageable. There's some very good apps out there that you can use to manage these drug interactions. Some of the drugs need to be stopped for the period of time on the Paxlovid. Some need to be reduced in dose. Some need to be replaced and substituted. But it's definitely manageable. And the more you do these kind of prescriptions, the better you get at it. So it's definitely manageable. But I had the same experience as you, Lynn. Some of the time I've tried to prescribe preemptive Paxlovid for patients, and the pharmacists have not known, or the patients have not known that was available. But one of the problems we're having in BC right now is many of the healthcare professionals that are prescribers, they believe that COVID is very mild and they don't think it needs to be treated with any medication. And then some prescribers are not aware that it's really important to treat patients even if they have mild COVID symptoms, because the goal is to prevent them from becoming more seriously ill. And if you wait and see, not only will they become more seriously ill, but they have a higher chance of getting long COVID, right? And
they miss the window, right?
exactly,
Because
what's the
it can
5-year
only
window?
be, yeah. So,
Yeah.
I find that frustrating, Susan, because today I was looking at even the information out there. So there's the BC action plan for Paxlovid. And on there, one of the things they say is, oh, you might be eligible for Paxlovid, but not everybody, but you may not need it if it's mild. So it contradicts everything we've been saying.
No.
It's confusing for patients. And the other thing I did today is I tried to figure out how, if ever I test or if ever I feel I have COVID, I'm getting symptoms and my rapid test is negative, how can I get a PCR test in BC? So I called London Drugs to see if I could get it there. So there's a few pharmacies that you can get a PCR test at London Drugs, but it's only if you're asymptomatic, and it's going to cost you something like $150. I might be off a little bit. So then I called Life Labs. So no way, you cannot get a PCR test at Life Labs, though they have a place. So if you're needing one for travel, you can access one, but you have to pay $150. And so I said, well, what if I'm a patient? Can I access it this way? And you could. They'll send the kit to you within 48 hours, I think, by FedEx, or maybe even the next day. But you have to pay $150. So to go a step further, I emailed this morning a friend who is a lab physician, and basically that friend emailed me back and said it's really difficult, and the only way was going through urgent care center, or possibly the infectious disease outpatient clinic, and then getting a rec and then going to Surrey, because I live in Fraser, to get a sample, to get a swab, basically, or a gargle test, something like that. So very difficult for people to get a PCR at this stage in British Columbia.
So you know what? My experience is that even urgent care, they're not able to check. So I've sent in patients that were clinically vulnerable with high fever, even chest showing pneumonia, and they still weren't able to get a PCR test. And so they've been told that if they only can get that if they need hospitalization, right?
Yeah, and my concern with that is that if we get a variant, that it takes time for your rapid test to turn positive. You've got five days. So it's a really small window in order to get access to Paxlovid if you're at day 3 or day 4 when your rapid test turns positive.
And rapid tests are notoriously, have a lot of false negatives too.
Right.
So,
I think what we'll do is I'll make a mental note to put the reminder to test with the rapid test using the throat and the nose, just to increase the sensitivity. But I think PCR access is a real problem in this province. Now, what do you tell your patients so that they're aware, to come in early or call early to get Paxlovid? What do you do?
One of the problems about Paxlovid use is that a lot of the public don't know about it. So, and its use. So what I try to do when I see any patient over 70 in my practice, I tell them about Paxlovid, its use, and how important it is that they get this within the first 5 days of their symptoms. And I also tell them that, and they're very pleasantly surprised when I tell them about preemptive Paxlovid. So I can give you this prescription for Paxlovid if you would qualify anyway, even if you're not ill now, to take with you in case you become ill, if you're traveling, for instance.
So that's the preemptive prescription for Paxlovid.
Exactly.
Okay, and then we'll put that up as well so that people can bring that in, maybe download that, bring that into their provider, so that they can get access if they're eligible with the current criteria in BC.
Yes, and some pharmacists aren't even aware that I've given prescriptions for preemptive to some patients, and the patients have been told, "Oh, you're not sick with COVID, you can't get this." And then I have to phone the pharmacist and say, "No, this is the new guideline. It came in November. We have preemptive Paxlovid now."
Yeah, it's pretty frustrating. And the thing to me that's really frustrating is the fact that we're not talking about long COVID, and that we need to protect people that have long COVID now from reinfection, or those people that have recovered from long COVID, because if they get reinfected, they may get a flare or a complete relapse. So
Yeah,
we need to really include them in the high risk category.
for sure. And Lynn, thanks very much for sharing that video by Professor Akiko Iwasaki, the Yale immunologist. It really emphasized to me how important it is to use Paxlovid and treat early to prevent long COVID. And I think if more people saw that video, like in the general public or other healthcare professionals, if they watched this, they would realize how devastating long COVID is and why we need to try to prevent it by treating, with Paxlovid.
Yeah, and it makes sense because one of the mechanism, as you know, for long COVID is the belief that there is, after the infection, there's a viral reservoir of the SARS-2 virus that sticks around, or viral proteins, and they lodge in tissues or organs. And so you've got this chronic inflammatory process going on with all the complications that are associated. So if you can stop the viral replication early, taking Paxlovid as soon as you get symptomatic, then your odds of getting long COVID are diminished. And we already have a Veterans Affairs study that showed that the risk of post-acute sequelae of COVID were decreased by 26%. It wasn't all the conditions that they looked at, but 10 out of 12. So, quite significant, and hopefully that'll be reproduced with other studies. But I don't think we can wait for randomized control trial with the amount of people that are getting long COVID right now.
No, and according to the recent StatsCan, it's 14.8% of Canadians who've had COVID have ended up having long COVID. And, family doctors like myself, we're seeing long COVID cases, new cases like all the time now. It's truly, frightening. And if you think about our next generation, like how many people are going to be affected with long COVID? How much disability are we going to see in our society?
It was interesting. A year or two ago, I remember thinking that when you're a medical student and you got somebody coming in with chest pain or a heart attack, you ask them about blood pressure, diabetes, hypertension. Now we're going to be asking, how many times have you had COVID?
Yes, totally. I've been teaching medical students for 17 years. And, they come to my office and I'm seeing patients. And, I don't plan this, but we're seeing long COVID patients. And I'm saying to my students, remember this, right? Remember, long COVID is going to be a disease that you in your lifetime, your career as a doctor, are going to see a lot of. And, don't forget this as one of your diagnoses when someone comes in with heart disease, when they have neurological problems, And then I tell them about, after the flu pandemic of 1918, I had a colleague who was a medical student in Israel at the time. And at that time, in the late 60s and 70s, they were seeing a lot of Parkinson's patients in Israel. And all of them were survivors of the 1918 flu pandemic. And so this is years and years later, right? Yeah, so we don't even know what's going to happen the next 20, 30 years. But I'm telling my students, keep this in mind, right? Remember to ask as a part of the history, did you have COVID in the past?
Yeah, absolutely. Is there anything else you want to add, or should we move to the Q&A part, Susan?
Let's go ahead with the Q&A.
Okay. All right, let me read this. I'm 69 and finally got COVID on Monday. Oh, I'm sorry.
Oh.
Do you have any advice that might help me persuade my doctor to prescribe Paxlovid? And I presume they're in British Columbia. What do you think? What do you say, Susan?
Unfortunately, if he has a CEV, so immunocompromised condition, that would probably automatically qualify. So it may be that his doctor's not aware. So any CEV condition could qualify. If he is a member of the First Nations, or if he has not had, all the vaccinations, and age 50 and above would qualify, if you're not fully vaccinated. But unfortunately, if you're a fully vaccinated person under the age of 70 and you're not immunocompromised, then unfortunately, even though you're 69, it's so close. I don't think there'd be a way we could get that prescription. But this is one of the things that Protect Our Province is trying to fight for. We would like to reduce the age of qualification for Paxlovid in BC to 50. And 50 is the inflection point. When we look at all the studies, when people get COVID after age 50, the hospitalization and mortality rate go way up. So, and if you look at the other provinces, some provinces, it's 18. I believe it's New Brunswick, right? Mm-hmm. 18 and up to qualify.
With no conditions.
Right. And in Ontario, Quebec, and Alberta, it's 60 and up, right? And
yeah, and this is a classic example of what I said. Your access to Paxlovid should not be determined by your postal code. And unfortunately, this is a repeat of what we saw with the rapid tests. If you remember the fiasco when Omicron was about to hit, BC could not access, British Columbians could not access rapid tests. They were sitting in warehouses.
Yeah.
So, John, I hope you do well. The one thing to add is rest, rest, rest. It's really important when you have COVID not to push through and to rest. And then if you start getting any serious symptoms, to consult early.
Yeah, especially if you have shortness of breath, so you cannot complete a sentence, or you can't walk a length of the room of your house without shortness of breath, that's when you have to get to the hospital. That's absolutely urgent to get to the hospital.
Right. Okay, next question.
Does Paxlovid help reduce the risk or severity of long COVID? If so, how much? And does it help some people more than others?
Well, so the study I mentioned was the Veterans Affairs study, and it's by a group that's Ella Lally and Zie, who have published a lot. It was a preprint, but all their previous studies have been published. So I'm just saying that because some people will say, oh, preprint, we can't base ourselves on that. That group has been outstanding with advancing our knowledge of COVID during the pandemic. So what they saw is that in the Veterans Affairs, using the Veterans Affairs database during Omicron, they looked at who amongst their veterans got Paxlovid and who didn't. And they looked at what was the benefit of getting Paxlovid versus if you didn't. And of course, there was decreased risk of hospitalization, there was decreased risk of death, like the other studies that I presented in a video. But they specifically looked at what was your post-acute sequelae of COVID, which is the same thing as long COVID, which is also called post-COVID condition. And that was decreased by 26%. Your risk of developing long COVID. And they looked at 12 conditions, 10 of them were significantly reduced at 90 days. And it was pretty much really heavy hitters. So your risk of developing a blood clot, so blood clot in your lungs or your leg, your risk of a heart attack, your risk of arrhythmia, kidney disease, fatigue, cognitive impairment, One of the thing that stood out is your risk of developing diabetes was not affected. So what it tells us is that there's several mechanisms, as we know, for long COVID, and it's possible that diabetes has nothing to do with having a viral reservoir after the infection, that you still have virus in your body or viral proteins that stimulate your immune system. So there may be another mechanism at play. So it looks really promising. And we'll show a video. Stick around at the end, and you can hear what Professor Iwasaki, an immunologist at Yale, thinks about that. All right, next question.
Can you provide a link to guidance on prophylactic Paxlovid prescriptions for people at higher risk?
Yeah, we will. And that's the preemptive prescription. Yes. Yeah, we'll provide a link to that. And it includes clinically extremely vulnerable, but also anybody who currently meets the criteria to get Paxlovid. And so what ends up happening, and I can say that because I got the prescription. So you get the prescription, and then if you're going away, like I was around Christmas, I got it filled. Although otherwise, you keep it on hand so that when you do test positive for COVID, it makes it easier to get access to the medication.
You probably don't want to get the prescription too early as well, because there are expiry dates on these medications. So you probably want to get it when you actually need to have it, when you're traveling in that. So don't get it too early.
Yeah, great point. Any other questions? What are your thoughts on procuring Paxlovid from the US?
So I'll talk about this. It's very, very difficult because although in the US, the age cutoff is 50, and you have to only have one risk factor, like obesity can be a risk factor to get Paxlovid, you must actually have a physician there certify that you have COVID. So you have to be able to see a doctor there and test and show that you have COVID. And then this prescription can then be sent to a pharmacist to get your Paxlovid from the pharmacy. Now, the pharmacies actually can dispense, and there's all sorts of things. I believe that you can get Uber to deliver it to your house and all that stuff. But before the pharmacist can accept that prescription, you must have a doctor certify that you have COVID, right? And that's the difficulty. If you're a Canadian seeing an American doctor there, it's not that easy.
And it's costly.
It's costly, right.
In the States, one of the things they did is they set up test and treat centers. So you go in, you get tested, and you get your treatment right away. And it would be something, having something similar would be helpful here, particularly in the conditions, in the situation I'm talking about, where you think you've got it, but your rapid test is coming back negative, and you don't want to miss that 5-day window from symptom onset. I think this reminds me, Susan, we haven't talked about that, that pharmacists in Quebec and in Ontario are able to prescribe. So why aren't pharmacists here able to prescribe Paxlovid?
I have no idea. But I mean, in terms of, it's all this thing about lack of public awareness, right? It's all the same kind of idea that Paxlovid is only for the very ill. Paxlovid, is not going to be for anybody but this very restricted group of people. And even though, as we said, we have close to 140,000 doses given by the federal government, right? And we've only used in BC about 10%. And although they've extended the shelf life of these medications, they are going to expire, just like those PCR tests ended up expiring before we used them all. And, interestingly, Lynn, last week in the Globe and Mail, there was an article saying that the federal government surprisingly didn't spend as much money as they projected on COVID pandemic relief. And, why is this? Well, of course, like they gave us all this Paxlovid, we didn't use it, so we didn't ask for more, so they didn't have to spend more. They gave us all this money for ventilation in schools and hospitals. We haven't used it all. We didn't even ask for more. So of course, they spent less because the provinces didn't ask for more. And why didn't they ask for more? Because they don't want us to think that COVID is still around, right?
The other thing that's interesting, having recently been in Quebec, is Quebec changed or expanded their access around December to Paxlovid, and so did Ontario, but not here in BC, which begs the question, why?
Alberta was, when I checked a couple months ago, their criteria was the same as ours, 70 and up and 3 medical conditions. But now Alberta's even reduced their age limit for Paxlovid to 60, right?
Mm-hmm. All right. Can we get Paxlovid in other provinces with less restrictive guidelines? Well, that's an interesting question. Let me start on that because I had this situation where I had to go and look after elderly parents in the fall, and I was concerned. And when I spoke to my parents' pharmacist in Quebec, that's where I learned that no, I didn't need a prescription from BC because I brought in my my prescription. That the pharmacist could prescribe it himself. And so, if you are in a province, visiting a province that is less restrictive, that's certainly, if you test positive for COVID, you may have actually an easier chance of getting Paxlovid in another province, which is pretty sad state of affair.
Mm-hmm.
I don't know that they have. I guess it doesn't matter if you're going to get it, but I don't know if they have a system of preemptive prescription in other provinces. But at the end of the day, if you're positive and you're in Ontario or Quebec, like I could have easily gotten Paxlovid in Quebec from the pharmacist.
Or drive to Alberta.
Right, it's been a bit of a drive.
Yes.
Any other question?
What are the diagnostic tests that are done to reach the diagnosis of long COVID? Well,
I think we need to direct Maggie to your long COVID talk that we should post on our website.
Yeah, so long COVID is a clinical diagnosis. There are no tests. So, and in my experience with my long COVID patients, most of their tests are normal. Their MRIs of their head, their echocardiograms of their heart, their CT scans, most of them are normal. And this is a bit problematic because in some situations, the workplace of these people are saying, well, all your tests are normal, so you should be fine to go back to work. But these people are obviously very symptomatic. They're barely able to, survive just getting dressed and getting up every day. How could they possibly go to work? So it is a clinical diagnosis, right? It's not a diagnosis that we can right now have good tests for.
But it is evolving. So
Yes.
there are studies out there that have shown that, for example, your cortisol level may be lower, your inflammatory markers may be higher. The problem is those are not regular lab tests. But there's a lot of work done by Professor Jeremy Nicholson in Australia at one of the precision, the National Phenome Lab, one of the precision medicine lab, if you will, and I think it'll be coming. But right now, it's really based on having had COVID and a constellation of symptoms or post-COVID condition temporarily related. So you develop diabetes, or suddenly your cholesterol's through the roof. So that's all part of what happened or can happen after COVID. All right.
What can people do to pressure BC Public Health to make Paxlovid more accessible? Good question.
Well, it's obviously we are voters, we are taxpayers. So the more people are irate about this issue, the better. The more you can write to your MLA, the more press coverage. You can bend the ears of your friends that are journalists and whatnot. If you remember, this is very similar to what happened with rapid test. And it took really a lot of people being upset and irate and showing that BC was an outlier to finally have rapid tests released. Any other idea, Susan?
I think that if the general public saw that YouTube video by Dr. Iwasaki, they would all want Paxlovid, have access to Paxlovid. When you see those people suffering from long COVID, right, and people of all age groups, like young children, whose lives have been destroyed, middle-aged people, older people, everyone would want access to Paxlovid if they got COVID to prevent that from happening to them or their family members, right?
Right. I think it's the last question. Any other questions, team? That's it. Okay. So so in BC, what Protect Our Province BC is advocating for is for the government and public health to release the eligibility criteria to Paxlovid and make it more available and accessible. And we're asking for age eligibility of 50. 50 sadly, from your immune system point of view, 50 is when you start getting old from your immune system point of view. And that's where your risk starts going up significantly for hospitalization and death. We're saying irrespective of vaccine status, a lot of the studies we looked at suggested that if you're more than 20 weeks out of your last dose of vaccination, you're at risk. Well, that's other than being a senior in long-term care or being clinically extremely vulnerable. That's most people in BC right now. If we look at the uptake of the last booster and the government not releasing another dose unless you're in high risk group. So we're saying age 50, irrespective of vaccination, allow people to get Paxlovid. And also, we need to protect anyone who has long COVID right now or has recovered from long COVID. And then there needs to be an education campaign of physicians and pharmacists and an education of the public, because they're going to need to push their healthcare provider to get access to it.
Yeah.
So let me just add, we need to change how we look at severe outcome. Deaths from COVID don't stop at 30 days, and long COVID is a severe outcome.
Yeah, and, we need to have everyone, the general public, talk to your doctors, your healthcare professionals about Paxlovid, and doctors and prescribers out there. Take a look at the extra criteria for patients to qualify for Paxlovid, and remember, it's worthwhile to treat people even with very mild COVID symptoms. And drug interactions are manageable. Don't let this scare you off and be the reason not to give your patients Paxlovid. Your patients will thank you for keeping them out of hospital and for not getting long COVID.
Yeah, and just to add, access to Paxlovid should not be determined by your postal code in Canada in 2023. And we need to broaden the access, and BC has to stop being a gatekeeper. So the last thing I'd like to do is maybe read a quote that struck me this morning in an email that I received. And it was about equity. So if there's one thing that I think a lot of us have learned about this past 3 years is how inequitable or how much there's inequity in the pandemic. And we're talking about now in the access of Paxlovid, but there's a bigger picture here. So let me just read this quote. Equity means giving opportunity to those who have the most barriers. In the case of the pandemic, those who have most barriers are those who have the most vulnerability to COVID-19. And that was written by Isabel Jordan, who's a patient engagement advocate and the chair of Rare Disease Foundation. And it hits home a little bit because, you know, if you look at BC, we have not done a good job at really addressing the pandemic through the social determinants of health and making medication, testing, healthcare accessible broadly, and particularly to people that are racialized groups or unhoused group or struggling with substance issues. So, and now we're upset about Paxlovid access, but these groups have struggled with equity for a long time. So I think it's important to keep that in mind. So if we can end with the video, we're going to play just the last 2 minutes of the video. But I encourage you, and I'm sure one of our teammates will be posting the longer version. It's 19 minutes. As Susan said, it's worth watching.
For someone who's newly infected, I would definitely recommend to get the Paxlovid right away, because the earlier the treatment, the more likelihood of you being able to eliminate the source of viral reservoir. And actually, treating early with Paxlovid or monoclonal antibodies is just, in general, great to avoid any of these 4 hypotheses of diseases from occurring, because the longer you allow the virus to replicate and cause damage, the more likelihood of you triggering these 4 types of disease outcomes. And there is even a study that suggests that getting vaccination within the first 12 weeks of infection reduces risk for developing long COVID.
After my second vaccine, my long haul symptoms started to ease up, which I guess happens to like 40% of long haul patients. But I still have shortness of breath sometimes, and heart palpitations and tingling in my hands. And it'll come out of nowhere, you know, and it's scary when it happens.
So even vaccination may be helpful during the early phase of infection. But if you wait too long, these things aren't going to be effective. I'm personally surprised that long COVID isn't at the center of discussion in public. Knowing how devastating this disease is, I am very hesitant myself to go out there and get exposed to any kind of COVID. I just think it's really gambling with your health, and it's not safe. I personally think that removing precautionary measures to prevent transmission is a very bad idea. I do absolutely ensure that my children are fully vaccinated, boosted if they're eligible, and are wearing masks inside while they're going to school or elsewhere. We need to layer protective, measures one on top of the other in order to reduce the risk of getting COVID so that we don't get long COVID either.
Sorry. I want to thank everybody that joined us today for this briefing, and I want to thank Dr. Susan Kuo for taking time away from her busy office to be with us today, as well as the team behind the scene. We're volunteers at Protect Our Province BC, and really we do this for you, and we hope it's helpful, and we hope you can join us in putting pressure on our political leaders to really make BC access to Paxlovid more equitable across our country, because right now we're the province with the least access. So thanks everybody, and stay tuned for our next briefing in the month of March. It'll be on long COVID, and we'll let you know the date on Facebook or Twitter. Thank you very much.